myasthenia gravis. Now, many students know a little bit about this condition already. What type of condition is this? Yes?
Autoimmune antibodies are produced
Autoimmune condition in which
acetylcholine receptors.
acetylcholine.
Very good. Okay, I got your answer. This is an autoimmune condition where the acetylcholine receptors present in neuromuscular junction are blocked, okay, by autoantibody. So this is myasthenia gravis. Wonderful. If you have this much concept already, then the topic will be very easy. Let's move further. So look at the definition. Myasthenia gravis is an acquired autoimmune disorder characterized clinically by weakness of skeletal muscles and fatigability on exertion. This term, fatigability on exertion, is a very, very important clinical feature of this particular condition. Now, in the morning, when the patient wakes up, there may be enough concentration of the neurotransmitter in neuromuscular junction. Throughout the day, okay, we may spend those neurotransmitters, they may be decrease in concentration. That's why towards the evening time or when we excessively work, those muscles will develop fatigability, they become very weak. This is the hallmark of myasthenia gravis, and this is a type of autoimmune disorder. Now let's talk about what are the causes. So in many people, this is a idiopathic condition. We don't know exactly what is the cause for this. Okay, idiopathic. One of the condition is known, okay, as a cause of myasthenia gravis, and that is thymoma. Okay, thymoma. Now this is a self-explanatory term. This is a tumor which develops from thymus gland, and this is usually a malignant type of tumor, thymoma. So this thymoma is commonly associated with this disease. And where is thymus gland present? Where thymus gland? Yes.
Sir, it reduce in the adults, sir.
Fibrosis in the adult.
Fibrosis in the adult.
Endemic area.
In child, it's present.
Okay. Now some of the important points you have shared. Okay, so let's talk a little bit more about it. Thymus gland is very active during the childhood. Okay, it is active and it is big in size in the children. In adult, it is atrophied, but it is still doing its job. Though it is atrophied, it is still doing its job even in the adult. That is the first thing. Second, where it is present. The anatomical area where thymus gland is present is anterior mediastinum. Anterior mediastinum. And it is also present in the superior mediastinum, near that area. What is the job of or function of this thymus gland? The thymus gland is mainly responsible for maturation of T cells. T cells are produced by bone marrow. Those T cells are naive T cell or the newly formed T cell. They go to the thymus gland. Thymus gland will select which T cells should live and which type of T cells should die. So those T cells are get matured and they are sent back into the circulation again. This is the function of thymus gland. Now tell me, if thymus gland is absent, what will happen to the patient?
Abnormal T cell
Immunocompromise.
Exactly.
T cell
T cells cannot get mature, and without T cells, the cell-mediated immunity will be very weak. So it results in defect in cell-mediated immunity. So this is a very important function of thymus gland. Let's move further. In this condition, of myasthenia gravis, now what is happening? The acetylcholine receptor antibodies are present in about 90% of the cases. So see there. Okay, this acetylcholine receptor antibody are present in about 90% of the patient developing myasthenia gravis secondary to penicillamine exposure. So we really do not know why this penicillamine causes production of this acetylcholine receptor antibody, but it may happen in the individual. And what is penicillamine? Which type of drug is this?
Sir,
What?
it is used in the
Copper
Wilson
chelating
disease.
agent, antidote of
Copper
copper or
chelating
load condition.
we used in Wilson disease.
Excellent. This is known as copper chelating agent. Copper chelating agent, and it is used in the treatment of Wilson disease. So it may be associated with myasthenia gravis by forming anti-acetylcholine receptor antibody. Now, various drugs can exacerbate the symptoms of myasthenia gravis. So there are different drugs which may exacerbate the symptoms of myasthenia gravis, like antibiotics. Okay, the important examples are aminoglycoside and ciprofloxacin. Now, when we talk about this aminoglycoside, one of the important side effects we have been teaching to you is the, a bit of muscular weakness. At the neuromuscular junction, this aminoglycoside will cause curare mimicking effect. So let me write that term here for you. Curare mimicking effect. Now you all know what is curare, isn't it? Curare is what type of drug? Yes?
Toxic type of muscle weakness, muscle atrophy comes.
Okay. This is a type of drug which relaxes the muscle. Okay. This is known as muscle relaxant actually. Skeletal muscle relaxant, curare. Okay, we do not use this drug usually. This is a toxic type of substance, curare. And a long time ago, if you study different, history books, then that curare is a toxic substance, right? So it is kept on the tip of the arrow, and when the person hits someone with a bow and that particular arrow, which tip is has a curare there, the person will suffer from paralysis because of the muscle relaxation effect. Now, why I'm bringing this point here? These aminoglycosides, streptomycin, gentamicin, kanamycin, tobramycin, and all those type of drugs, they have this particular effect which may look similar to the curare effect. Okay, but this is reversible after we discontinue this medicine. Ciprofloxacin can also result a bit similar type of effect. Let's move on. Beta adrenergic receptor blocking agents like propranolol, okay, can exacerbate the symptoms of myasthenia. Lithium, this is an important drug which is used in the treatment of bipolar disorder or mania. Chloroquine, this is anti-malarial drug. Prednisolone, it's a type of steroid, and anticholinergic like trihexyphenidyl. Okay, so all of these may exacerbate symptoms of myasthenia gravis, okay, because of some of the effect. So it is not a good idea to give this drug if somebody is having myasthenia. On the other hand, the neuromuscular blocking agent like vecuronium, okay, pancuronium, even curare should be used very cautiously in myasthenic patient to avoid the prolonged neuromuscular blockade. They are already having muscle weakness because of those abnormal antibody. On top of that, if we give this neuromuscular blocking agent there, then the patient will have prolonged muscular weakness. Okay, so this is not a good combination to do in this situation. Now, let's go and talk about an important part of this lecture, that is pathophysiology. What is exactly happening in this neuromuscular junction? So all of you, please pay attention here. Now see this. This is the presynaptic terminal. Presynaptic terminal, because this is a synapse. This neuromuscular junction is an example of synapse. So presynaptic terminal or end. And these are the different vesicles. These vesicles are having neurotransmitter known as acetylcholine here. When the action potential comes to this nerve ending, okay, these vesicles will move towards the membrane, presynaptic membrane, and they'll rupture and the neurotransmitter will be released here. These are the receptor. These are called nicotinic receptor for acetylcholine, which are present in the neuromuscular junction. So this acetylcholine will bind to these nicotinic receptors, and then the action potential will start again. That's how the muscle contraction will occur. So this is the basic thing. This is the physiology. I am sure every student knows this. Now what happens in this condition known as myasthenia? We have some autoantibody which are already present there, and this autoantibody can block this acetylcholine receptor which are present in the neuromuscular junction. Now the acetylcholine cannot bind there to the receptor because they are already occupied. Remember that they are already occupied, so that the action potential cannot be passed towards the muscle, and muscles will become weak. This is the main problem in myasthenia gravis. Now what can we do regarding the treatment? Okay, pay attention here. If I increase the concentration of this acetylcholine in this neuromuscular junction area, this acetylcholine may displace those particular antibody, and then it may start to work again. This is one of the very important mechanism which we utilize during the treatment. Okay, so let's move on. So let's come to the slide now. The antibody in myasthenia gravis are directed against the acetylcholine receptor at the neuromuscular junction of skeletal muscle, and this is present in almost 80 to 90% of the patient with myasthenia gravis. So this is an important investigation done in myasthenia people. Now, another important question which is asked to the student is, why myasthenia gravis is considered autoimmune disorder? What are the immunological basis for myasthenia gravis to be considered as an autoimmune mechanism or disease? And the answer is presence of that autoantibody. That is the one answer you can give very confidently. And another, the same patient may be having other autoimmune disease as well inside the body. So we need to search for those. We need to take a very good history. We need to do some important investigation to find out whether other autoimmune diseases are present there or not, like the thyroid gland disorder. Thyroid gland disorder. There are two important conditions which may occur in the thyroid gland, and both of those are autoimmune. Can you name them?
Grave disease and Hashimoto thyroiditis.
Hashimoto thyroiditis, grave disease.
Excellent. Graves disease and Hashimoto's thyroiditis, both are autoimmune condition. Okay, both are autoimmune. SLE is autoimmune disease. Rheumatoid arthritis is autoimmune disease. Sjogren syndrome is autoimmune disease. Pernicious anemia is autoimmune disease. Type 1 diabetes is autoimmune disease. Addison's disease is an autoimmune condition. So many are there. So same patient may be having any one of them. And let's not forget about vitiligo. Okay, let's not forget about vitiligo. Let me write that here. So vitiligo is known as marker of autoimmune diseases. It is a condition on our skin, okay, where our skin will lose those melanocytes. So that area will be hypopigmented. This condition is vitiligo. This is the autoimmune disease, and this is known as marker of autoimmune conditions. Don't forget this. When we talk about dermatology, we'll study vitiligo there. Let's move on. Patients with myasthenia gravis will have a therapeutic response to various immunomodulating therapy like plasmapheresis, corticosteroid, IVIG, as well as other immunosuppression drug and even thymectomy. So all of this also support this disease is an autoimmune disease because of this mechanism. Okay, because the abnormal antibody is filtered by plasmapheresis. The synthesis of those abnormal antibody will be decreased by corticosteroid. The action of them will be blocked by IVIG and thymectomy, because thymus gland is having problem like thymoma in these conditions. So all of them will give us additional evidence that this myasthenia gravis is a type of autoimmune mechanism. Now let's move on. Okay. Now see there. So let's talk about some other important points regarding pathophysiology. Sometimes patient, they don't have anti-acetylcholine receptor antibody. They are known as seronegative myasthenia gravis patient. Almost 80 to 90% of the patient have acetylcholine receptor antibody, but about 10 to 20% of the patient they don't have. So they are known as seronegative myasthenia gravis. But in those patients, we have another type of antibody, which is against the muscle specific kinase. Okay, muscle specific kinase, also known as MuSK in the short form. This MuSK plays a critical role in postsynaptic differentiation and clustering of the acetylcholine receptor. Now, if this mechanism cannot occur in postsynaptic junction or acetylcholine receptor which are present in the postsynaptic membrane, then also the muscle will be weaker because there is no transmission of the signal there. So it also acts in the same fashion like myasthenia gravis. But the percentage of these people will be less, around 10 to 20 only. And many of them are female, and this has got a very important problem, that is it affects respiratory and bulbar muscle. Respiratory and bulbar muscle. What do you mean by bulbar muscle? Bulb means what?
Muscles for speech in eyes.
Tongue,
Tongue.
You are right. This bulbar muscle means those muscles which are supplied by cranial nerve. Okay, which are supplied by cranial nerve. Bulb is actually the term for brainstem. So you are absolutely correct if you answer like this. Different muscles which are supplied by cranial nerve, they are also affected in case of this type of condition. So remember, seronegative myasthenia gravis is the term which is there. Now, after this, let's talk about the clinical feature. It is very easy concept for you after you understand the pathophysiology. Regarding the sex, the female to male ratio is 6:4. Just like any other autoimmune disorder, this myasthenia gravis is also more common in female. Regarding the age, it presents at any age, and in female, mainly the third decade of life, okay, are affected. Means 30 to 40. Third decade of life means that. Male incidence in 6th or 7th decade in much older people, but it is more common in female. So we have to remember the third decade of life in female. Very important point in myasthenia is there is a fluctuating weakness which is increased by exertion. Absolutely important one. In the morning time, the person can wake up quite nicely. The person will do the regular activity in the morning time. Okay, they can go to office also quite nicely. But during the evening time, they cannot sometimes even stand from their chair in the office. They cannot even open the eye. Okay, and sometimes the jaw or the lower jaw is hanging down. They cannot even close the mouth. These are severe features of myasthenia gravis. Now see here, the weakness increases during the daytime and improves with the rest. And some of the muscles which are weak quite early are the extraocular muscles which are present around the eyeball. As a result of this, the person will develop ophthalmoplegia and ptosis, drooping of the upper eyelid. Very common feature of myasthenia. And many of the patients have bulbar muscle weakness also. Let's move on. The weakness tends to spread from the ocular to facial to the bulbar muscle, and then it will move distally to the trunk and the limb muscle. So see there, this is a very typical spread. It tends to spread from the ocular first to the facial and to the bulbar muscle, and from there to the truncal and limb muscle. So the first symptom which the patient may complain is ophthalmoplegia and ptosis. After that, weakness of the face. The face would be very blank, and then probably the person cannot flex, support the head also. The neck muscles are also example of bulbar muscles, and then it will move on to the trunk and the limb. Proximal weakness is greater than the distal, because this is a feature of myopathy than the neuropathy. I already explained this point to you in the previous classes. And sometimes the symptom may remain limited to the extraocular muscle and eyelid muscle for years, rather than going distally. So these are the fortunate or the lucky patient, we should say, because they don't have more weakness of the limbs. If this patient have intercurrent illness, any viral or bacterial illness or any other illness, or if they use those medication which we have listed before, like beta blockers, isn't it? Like penicillamine, for example, like aminoglycoside, okay, then they would suffer more severe type of weakness, okay, and sometimes they are also known as myasthenic crisis. Okay, they are known as myasthenic crisis, and they can also have respiratory compromise. So that's why we should be very careful which type of drugs, okay, are harmful in this type of situation. Okay, let's move on. Now let's examine these patients clinically. What are the important physical examination findings? Regarding the weakness, it is usually proximal and symmetric type of weakness. Now every student knows what is proximal weakness, isn't it? Proximal means the proximal group of muscles are affected. In the lower limb, these are the thigh muscles and the buttock muscles, and in the upper limb, they are upper arm or arm muscles and the pectoral girdle muscles. So they are mainly affected. Sensory examination and deep tendon reflexes are normal. So why they are normal? What's the explanation? Why? Yes?
Sir, because there is no peripheral neuropathy, no involvement of sensory.
Exactly. Very easy question, isn't it? Sadat is answering quite well. So because there is this no involvement of the peripheral nerve, okay, this is purely the involvement of neuromuscular junction. So sensory nerves are not affected here. That's why these are normal, the sensory examination, and even deep tendon reflexes are normal here. There is facial muscle weakness and the face may be blank. Eyelid weakness can lead to ptosis. Ptosis is drooping of upper eyelid. Now tell me some other causes of ptosis immediately. What are the other causes of ptosis? Yes?
Cranial F3 damage.
And 7 apple.
Also 7,
Okay.
6.
Oh, third nerve palsy. Good. Completely agreed. Any other? Any other cause?
Sympathetic.
Horner syndrome.
Horner syndrome.
Very good. Very good. I was waiting for that answer actually. Horner syndrome. Excellent. Okay. Horner syndrome. as a medical student, you should not miss these two important causes of ptosis. Some others you will study in ophthalmology. If there is something wrong occurring on the upper eyelid, then also there will be drooping of the upper eyelid. That is altogether very different type of causes. Okay, but from the neurology, these two questions are very important. Remember, some students were answering seventh nerve palsy also results in ptosis. That's a wrong answer. Seventh nerve palsy doesn't lead to ptosis. It will cause, okay, overall weakness of orbicularis oculi muscle. So the person, okay, cannot close the eye properly. This is not ptosis. Ptosis means, remember, only the upper eyelid is drooping downwards. Okay. Now, which muscle is affected in ptosis? Name that muscle. What is the name of that muscle?
Levator
Superioris.
Very good. Levator palpebri. Okay. Levator palpebri superioris. This is the muscle. Levator palpebri superioris is the muscle which is affected in case of ptosis. And in Horner syndrome, this is the problem of sympathetic neuron damage. There is a problem of sympathetic neuron damage. So one small muscle which is known as Muller's muscle. Muller's muscle is a part of that levator palpebri superioris, and this Muller's muscle is only supplied by sympathetic neuron. That's why in Horner syndrome there is a chance of ptosis, but that ptosis is not as significant ptosis as third nerve palsy. Some other component of Horner syndrome, I want to get that answer now. Apart from ptosis, what are the other component of Horner syndrome? Yes?
Meiosis,
Meiosis and
meiosis, meiosis and hydrosis.
Good. Meiosis and hydrosis. Okay, and one more. One more is there. In ophthalmos. Okay, in ophthalmos. Now, see there, meiosis is a constriction of the pupil. Meiosis, because the function of sympathetic neuron is dilation of the pupil. Sympathetic neurons are damaged here, so the pupil will be constricted. So meiosis, very easy to explain. And hydrosis, lack of sweating on the forehead area. And inophthalmos means the eyeball is sunken inside. Those the pad of fat which is present behind the eyeball are atrophied in case of Horner syndrome. So there is inophthalmos. So these are some other component of Horner syndrome. Quite a catchy question in the exam. That's why we are revising it here. Now let's move further. Some other clinical features of Horner syndrome, the myasthenia gravis are bulbar muscle weakness, which may result in nasal regurgitation of food, especially the liquid. It may result in aspiration as well. This occurs because of lack of gag reflex. Chewing and swallowing may become difficult, and there is severe jaw weakness. Sometimes patient jaw is hanging, so patient will prevent the hanging of the jaw with the support from another hand. And this is a very typical finding. So see this, patient may sit with the hand on the chin for the support, meaning the jaw is hanging downwards, so the patient is supporting it. That jaw is that much weaker, sometimes in case of myasthenia gravis. And one of the very important problem is a respiratory muscle weakness. It may produce acute respiratory failure, and only one treatment is available during that time, that is immediate intubation and ventilation. And meanwhile, a lot of other treatments are going on. We can use IVIG, we can use plasmapheresis, we can use corticosteroid, we can use other different drugs, okay, which are known as acetylcholine, esterase inhibitors, something like that. So all those medicines will act from the side, but at this moment when there is respiratory failure, the most important treatment is intubation along with ventilation. Otherwise, the patient will die. Now, let's see some of the picture here. All of you, please pay attention on your slide. So, what is there in this first picture? What can you see here?
Ptosis.
Ptosis.
The scleral mucus, so yellowish and ptosis.
Exactly. Okay. Look at that. There is bilateral ptosis present. Bilateral. See this? The both upper eyelid are drooping. This is the typical picture of ptosis. And look at the facial expression here. The facial expression tells us everything. This boy, you know, is not showing any facial expression. It looks like a blank type of face. So he already having weakness of the facial muscle as well. Now this is an older person who is also having bilateral ptosis, a typical type of presentation. Now another picture, just have a look here. So can you please comment on this? Where the ptosis is present? Where in this patient? On which side?
On the left
Right.
side.
Left side.
Okay.
Left side.
The patient
left
left side.
Exactly.
Patient
Patient
left.
Patient left side. Uni
Our
left.
right. Our right side. Patient left side.
Exactly. Patient's left side. Okay. Patient's left side. You always explain this from the patient's side. Okay. Not from your side. Always from the patient side. So this is the left side of the patient. Here is the right side. So this eye is affected. So this is ptosis on the left side. Here also on the left side. And let me tell you one thing. This can happen sometimes in myasthenia, but it has a lot of differential diagnosis as well. One of the important differential diagnoses of myasthenia gravis is called Lambert Eaton myasthenic syndrome. Lambert Eaton myasthenic syndrome. I'm sure you have heard this term before. It is strongly associated with carcinoma of the lung, especially the carcinoma of the lung or bronchogenic carcinoma. Small cell carcinoma are mainly associated with Lambert Eaton myasthenic syndrome. So it is also considered as a paraneoplastic syndrome. That is known as paraneoplastic syndrome. Remember that. We have studied that already in the topic of malignancy in pathology. Now let's come back to the topic. It's a rare presynaptic disorder of neuromuscular transmission in which quantal release of acetylcholine is impaired. Now, if you compare between the myasthenia gravis and Lambert-Eaton syndrome, there is a difference at which site the problem occurs. In this condition, there is a problem in presynaptic membrane, okay, or presynaptic terminal, I should say, because there lies the vesicle where acetylcholine is stored, and in this condition, the acetylcholine release from those vesicles is impaired. So this is a very important point. As a result of this, there is proximal muscle weakness, depressed tendon reflexes, and autonomic changes, which are not very common in myasthenia gravis. Remember, in myasthenia gravis, the tendon reflexes are usually normal, but here they are also depressed. Along with them, some autonomic changes are found. It is the result of an autoimmune reaction in which antibodies are formed against the presynaptic voltage-gated calcium channel. They are present in the presynaptic, junction or the membrane or the terminal, whatever you want to say. So because of this, the acetylcholine cannot be released even after the action potential arrives there, resulting in weakness. Now, a bit similar to myasthenia, here also the proximal arms and legs are affected, but legs are more affected than the arms in this condition. Okay. In contrast to myasthenia gravis, the weakness affects the legs more than the arms. So there is a slight difference. One of the very, very important point I should ask in the history is the weakness is often relieved temporarily after exertion.
or physical exercise. Exactly opposite of the myasthenia gravis. And this is an important point in the history. And that can help us, to distinguish which type of weakness is this. Is it myasthenia or Lambert Eaton syndrome? Another point, this is seen mainly in malignancy, isn't it? So the person may have a lot of other features of malignancy, like extreme weakness, loss of weight, breathing difficulty, cough, chest pain, hemoptysis, old age. All those points are also there. So just now we talked about around 60% of those with Lambert Eaton syndrome have an underlying malignancy, importantly small cell cancer of the lung. That's why it is also regarded as a paraneoplastic syndrome. So let me ask this question to some of the students. What is the meaning of paraneoplastic syndrome? Who can answer this? Yes?
So set of symptoms that cannot be explained by the malignancy or metastasis of the tumor.
Okay, good.
So the malignancy is present in different organs, and it can spread to the other organs too, like thyroid gland, parathyroid gland. It affects so many organs.
Okay, the meaning is there. Both of the students are answering in a bit different way, but the meaning is there. Okay, very good. This is how you should answer in the exam also. Now, all of the other students, please pay attention here. Paraneoplastic syndrome can be very important feature of malignant tumor. Malignant tumor. In this condition, the malignant tumor produces some secretion or some substance. It may be enzyme, it may be hormone, okay, it may be some other types of protein, which will go away from the site of origin and causes some problem there. Okay, it is not because of metastasis. Please remember this. Metastasis means the cancer cell themselves are going to that region and causing problem. So paraneoplastic syndrome is not metastasis. It occurs because of secretion of certain substances by the malignant cells. Maybe enzyme, maybe hormone, maybe some other protein or substance, which will produce some clinical effect. This is paraneoplastic syndrome. So some of the good example, okay, some of the good examples are like this, like some antibody which are produced by the tumor cells. Those antibodies are causing problem in the presynaptic nerve terminal, causing Lambert Eaton syndrome. Parathyroid hormone, like hormone or secretion, may be secreted by squamous cell carcinoma of the lung, and now that can cause hyperparathyroidism, isn't it? ACTH-like substance may be produced by the tumor cells, especially small cell carcinoma of the lung, may cause Cushing syndrome. So these are some of the good examples for you. Never forget, important question in the exam. Lambert-Eaton myasthenic syndrome usually occurs in people over 40 years of age, but it may occur at any age. And the diagnosis is usually confirmed with the help of electromyography and blood test. Electromyography, okay, is the test of muscle, just like ECG we do for heart, EEG we do for brain, we do EMG for the muscle. Now, regarding the treatment, drugs often used for the treatments are corticosteroid. Okay, see here. So let me underline here. Are corticosteroid, azathioprine, IVIG, intravenous immunoglobulin, and pyridostigmine. Now, if you analyze this drug, many of these drugs are immunosuppressive drug. Intravenous immunoglobulin is commonly used in this type of situation. We have studied this before. And what is pyridostigmine, by the way? What type of drug is this? Who can answer?
Cholinergic.
Acetylcholine agonist.
Okay. Now listen. Pyridostigmine.
Acetylcholinergic agonist.
Exactly. Neostigmine and physostigmine and even hydrophonium. These drugs are known as acetylcholinesterase inhibitor. Acetylcholinesterase inhibitor, or you can simply say anticholinesterase. Okay, anticholinesterase. Please mute yourself. So what they do, they will block the enzyme which is necessary for the degradation of acetylcholine. As a result of that, acetylcholine will be collected in the neuromuscular junction for a longer time and in a higher concentration. So they produce cholinergic effect. Okay, we'll talk about that in the treatment of myasthenia gravis also. These are very important drug in the treatment of myasthenia as well. Occasionally, we have to go for plasma exchange to remove those autoantibody. Let's move on. Now, after going through those Lambert Eaton syndrome, what are the lab investigation done for myasthenia gravis case? Now, the most important, a pathophysiological point here is the presence of anti-acetylcholine receptor antibody. So, if we detect that in the plasma, okay, we get the diagnosis. See there. This test is reliable for diagnosing autoimmune myasthenia gravis, and the results are positive in about 80% of the patient with generalized myasthenia and in 50% of those with pure ocular myasthenia. Ocular myasthenia means only involving the eye. Okay, so 80% of generalized myasthenia and 50% cases of ocular myasthenia. So this is a good test to do. If it is positive, it really helps us regarding the diagnosis. Now, another important test is chest X-ray, because thymoma is very commonly associated with myasthenia gravis, and we may detect this thymoma on chest X-ray. And if this chest X-ray is not confirmatory, you can go for CT scan of the chest. CT scan, okay? Don't hesitate to order CT scan. Now, these are the X-ray of the AP view and the lateral view, which is shown here. Okay, you can see a mass here on the lateral view. On AP view, usually it should be present a little bit upwards. Okay, this is the hilar region. This is hilar region. This is a little bit way down for the thymus. Thymus mass is usually present here in this area. Very easily seen in the lateral view though. Look at this. There's a density difference on the anterior mediastinum. So this type of mass, if it is seen on the X-ray, you can go for CT scan, and CT scan will confirm the diagnosis. Now, please pay attention. Another important lab test which we do for the diagnostic purpose is hydrophonium or tensilon test. Hydrophonium or tensilon test. Now, this is a drug which can be used for the treatment also, but it is a very short-acting drug. So rather than it is used for the treatment purpose, it is used for the diagnostic purpose here. This hydrophonium is acetylcholinesterase inhibitor drug. Okay, just like other drugs like pyridostigmine and neostigmine. So what it does is it inhibits acetylcholinesterase enzyme. After doing so, the concentration of acetylcholine is increased in the neuromuscular junction. I'm sure every student understands till here. Now, if there is excessive acetylcholine concentration there, it can, displace the antibody which are binding to the receptor, and there will be good conduction of the signal resulting in contraction of the muscle. That's what we want to see after giving hydrophonium. Hydrophonium or tensilon is a trade name, is a short-acting acetylcholinesterase inhibitor that improves muscle weakness in patients with myasthenia gravis. And why it causes, improvement in muscle weakness? Every student can answer that, because it leads to increased concentration of acetylcholine in neuromuscular junction. Okay, that is the reason. To perform this tensilon test, a test dose of 0.1 ml of 10 milligram per ml of hydrophonium solution is administered. If no response and no untoward effects are noted, remainder of the drug is injected, and a quick effect can be seen. Now, one very important concept I am going to provide here. Please listen properly. Sometimes in the clinical practice, we are quite confused with cholinergic crisis and myasthenic crisis. Now, why are they confusing with each other? Because the ultimate clinical features may be similar. That ultimate clinical feature in this condition is weakness of the muscle. Weakness of the muscle is seen in both conditions, but there are definitely certain differences between them. So let me clarify first. Cholinergic crisis means excessive cholinergic activity. And remember, if we give overdose of the medicine like neostigmine, pyridostigmine, physostigmine, and even hydrophonium, there will be excessive cholinergic activity because of the collection of acetylcholine in the neuromuscular junction. On the other hand, myasthenic crisis means there is very less amount of neurotransmitter, okay? Very less amount of neurotransmitter collected there in the neuromuscular junction because of excessive collection of autoantibody. Now, how we separate these two? A very easy test that is also done by hydrophonium or tensilon test. After giving hydrophonium, if the paralysis of the muscle, okay, improve, means the strength has come back. This is a case of myasthenic crisis. Whereas if the paralysis or weakness of the muscle, rather than paralysis, I should use the term weakness here. If the weakness of the muscle worsen further, it is a case of cholinergic crisis. I'm sure you have understood this because hydrophonium will cause excessive collection of acetylcholine in the neuromuscular junction. So the weakness of the muscle further, increases in case of cholinergic crisis. Let's move on. Now, what is the treatment? Okay, that's the final part of the lecture. What are the treatment? Treatment can be done by using some immunomodulatory agent like corticosteroid, azathioprine, cyclosporine, or cyclophosphamide. These are called immunosuppressive drug. This is a autoimmune disease, so there is a big role of these drugs in the treatment. There's no need of any discussion here. Another important modality of treatment is acetylcholinesterase inhibitors. Pyridostigmine, physostigmine, neostigmine, and hydrophonium. These are the good example. But in the clinical practice, okay, pyridostigmine and neostigmine are very commonly used. Physostigmine can cross blood-brain barrier very easily. Okay, so it is mainly used in the treatment of overdose of atropine. Now, tell me, what is atropine? What type of substance is atropine? Yes?
Anticholinergic antagonist.
Antimuscarinic.
Exactly.
Antimuscarinic.
Absolutely. You can answer in both way, anticholinergic or antimuscarinic. Okay, both are acceptable answer. Antimuscarinic is even better than anticholinergic. Yeah, but never mind, both are correct answers. So what is happening there? Excessive atropine, okay, can produce some toxic effect. If we want to reverse that toxic effect, similar, we want to increase the level of acetylcholine in those areas, and that is done by this anticholinesterase inhibitor drug. So physostigmine is very commonly used in that purpose. Don't forget this explanation, okay? Because in the future, when you appear in different exams, this type of questions may be asked to you. Another modality of treatment is plasmapheresis and thymectomy. Plasmapheresis is like a filtration of plasma. We remove those autoantibodies from the plasma, and thymectomy is removal of thymus in case of malignancy. Now, plasmapheresis or plasma exchange is an effective treatment, and in this treatment, the weakness improves within days, but the improvement lasts only 6 to 8 weeks because the body will again synthesize, okay? The body will again synthesize some of the antibody. isn't it? Until and unless you go for the curative treatment, the antibody will be formed again. That's the important point. It is thought to act by removing circulating humoral factors, that is acetylcholine receptor antibody and immune complex. So it is an effective type of therapy. Now, anticholinesterase inhibitor, we have already talked about. Pyridostigmine and neostigmine are very commonly used in the clinical practice. Physostigmine and hydrophonium are not commonly used for the treatment of myasthenia. But hydrophonium is used for the diagnostic purpose, whether this is a case of myasthenia gravis or not, and to differentiate whether this patient is in myasthenic crisis or cholinergic crisis. And these are the different examples of immunomodulatory therapy: prednisolone, azathioprine, cyclosporine, cyclophosphamide, mycophenolate mofetil, and you can add few more there. Okay. Now, finally, what's the complication of myasthenia gravis? Respiratory failure is one of the dreadful complications. A patient can die because of respiratory failure, and ventilatory support may be necessary sometimes. Dysphagia is difficulty to swallow. Aspiration pneumonia can occur because of the bulbar involvement. Okay, the bulbar muscles may be affected, so aspiration pneumonia is a possibility, and there may be complications secondary to drug treatment. Just think about which type of drugs we are giving. Very powerful immunosuppressive agent. So they themselves have a lot of side effects. So all of these can be considered under complication.